All right, well, if we missed out on polycystic kidney disease, you got to read it and like go to the book, I guess. Okay, so now next disease, we're going to talk about, there we go, diabetic nephropathy. Again, if you're not sure what it is, what is this? What does the name of it tell you? It's from diabetes. The diabetes is causing some issue. It's the nephropathy. So essentially, it's causing the nephron, that's kind of the functional unit inside the kidney. It's causing damage to those nephrons itself. It's the most common cause of chronic kidney disease is diabetes itself causes this nephropathy. And so when somebody has kidney disease, most patients, it's going to be caused from diabetic nephropathy. Atherosclerotic changes decrease the blood flow. We haven't talked about atherosclerosis in general, but essentially it's damage to the blood vessels in the kidney. And so they're not able, the kidney doesn't get the blood flow that it really needs. And that's what causes that damage itself. Because of this, chronic kidney disease can develop. So there's kind of this pathway we see with diabetes causing a lot of issues with patients. Kidney disease is one of the biggest risk factors that they have. We've talked about infection and some of the other issues. Hey, if you're just joining us, all right, go ahead and join the Minty. The code is right over here. And so controlling patients' diabetes, we see again and again how key it is to keep those patients in like a good blood sugar range, because if we keep it well controlled, we can prevent a lot of these things, a lot of these complications from developing. All right, so first question for you. Which of these actions by the nurse should we include on our care plan, move this up here, to help prevent or slow the progression of diabetic nephropathy, excuse me. Select all that apply. And I think I fixed it, finally. I think, yeah? Okay. Oh, so exciting. And there we go. Hey, you guys did great. Look at that. So yeah, you guys got control the blood glucose. Again, I keep saying these things, forgetting that I have a question about them. So I did just say that. But we also think about controlling the blood pressure, because we know that high blood pressure over a long time can also cause damage to the blood vessels. And strict protein is also one of those. Protein is pretty hard to break down in the kidneys. It's not hard as in like you and I have trouble with it, but once the kidneys start not functioning as well as they usually do, protein can be kind of hard to break down. So a lot of times our patients, we're talking later, with chronic renal failure, when their kidneys just don't work very well at all, we usually have them restrict the amount of protein that they're eating because that's harder on their kidneys to break down. Okay, so now moving next. So continuing with diabetic nephropathy, what do we do about it, right? So our early interventions, like we said, we're going to help control their blood sugar, control their blood pressure, maybe try to restrict some of that protein in their diet, just so their kidneys aren't working so hard. Later, we might require dialysis, which we're going to talk about a little bit as a treatment for this kidney disease. We're going to talk about transplantation a little bit. Nursing care is really important. How to teach patients not only how to control their blood sugars and their blood pressure, I think that we can get patients to understand the why. Why is this important? I think that's where patients will actually change behaviors. Where they will turn and maybe, hey, oh, I actually understand why you don't want me to eat this cheeseburger because of all the protein. Maybe they will actually make a difference or make a change. All right, so next one, nephrotic syndrome. Again, let's look at the word nephrotic. We're already talking about kidneys, so we know. And then syndrome, like, oh man, what is nephrotic syndrome? Essentially, this is where suddenly the urine, or not the urine, but the kidney starts just over excreting large amount of proteins. It's like the insides, the membranes in the kidney get real thin or they're really permeable, and they're just like, instead of normally keeping things in, they just start excreting. Because of that, it's like all of the balance and regulation that our kidneys normally do, it's all out. So what we see in that is our lab values get out of whack. We tend to get from edema, ascites, enteritis. Yeah, in the stomach, so we can build up fluid in our abdominal cavity. Just when people just have too much fluid for whatever reason, it can be caused from different reasons, but it can be caused by nephrotic syndrome. Anasarca, you guys know what that one is? It's just massive, overwhelming whole body edema. If you've ever seen somebody with it, you will remember, because you're like, oh my gosh, you look like you you remember when you were a kid and you had those little toys or like foam things and they swell up and they like get a bunch of fluid in them. It looks like somebody that happened to a person. And then if we can, we get the diuresis and that person comes back to like regular size. Like they just get so swollen. Sometimes the liver can get a little bit involved and produce these lipoproteins, and you might see some foamy urine from these patients. So the treatment, we try to figure out what caused it. What caused the body or the kidneys to start having all this malfunction? There can be some clotting issues that happen as well. So we usually want to try to put them on some anticoagulants or maybe some, what would be a type of anticoagulant we'd put somebody on short term? Heparin, yeah, heparin. If it was longer term, what would it be? Probably warfarin. There's a bunch of like other ones that are out there now as well. But with nephrotic syndrome, some of the nursing care that we're going to do, especially if they have all this edema, we're going to be doing daily weights every day. Because that's the best way for us to track what the general fluid balance of that patient is, right? We're going to do really strict INOs, but it's the daily weights that are going to tell us how much fluid we're actually diuresing over time, or how much fluid there may be continuing to gain. We're also going to teach them about infection prevention. We're going to try to do some malnutrition prevention because their body's just wasting a lot of these nutritions. And then thrombosis prevention. What's thrombosis? A blood clot, right? Yeah. So in addition to the like anticoagulant, what else are we going to be encouraging patients to do? Yeah, walk, exercise. A lot of these patients are in the hospital, so it might be just get up and walk in the room, in the bed. Hey, just move around, do something, try to get that blood flowing. All right. New diagnosis, nephrosclerosis. So again, this is something that it's where the kidneys are damaged by sclerotic changes to the blood vessels. So this causes a lot of high blood pressure. Some of the interventions we would do is try to decrease that blood pressure overall. There's not a great way to fix it once it starts. It's more of just managing the symptoms. You guys are actually going to start clinicals. You're going to be talking more about nursing diagnoses with your care plans, right? Somebody with nephrosclerosis might have an infected malignancy, meaning maybe they have some high blood pressure, but over time cause some nephrosclerotic changes and cause some damage. All right, next one, glomerulonephritis. That's where you get this inflammation in the glomerulus of the kidney itself. The glomerulus, kind of like nephrotic syndrome, where everything gets more porous. There's antibodies that actually form though with the glomerulonephritis. And then proteins, white blood cells, red blood cells, that all just gets leaked out and the body is losing those again. So there's a lot of similarities with glomerulonephritis and nephrotic syndrome in some of the pieces where they're just like losing a lot of the fluid and a lot of the proteins in the urine. The causes of why do patients have this? Well, this is nice. At least it's not just high blood pressure, like causing it and all this damage that we can't reverse. But acute post-streptococcal infection. Somebody, especially if you have a really bad strep infection, especially one that may be a septic or like goes to all of your body, patients can have glomerulonephritis. There's also good pasture syndrome. That's an autoimmune disease that where patients can end up getting glomerulonephritis because of the autoimmune, like the body is attacking itself essentially. Or sometimes patients can have glomerulonephritis from something, and then it just ends up being kind of a recurring thing, and it's a chronic thing you have to deal with. So it becomes chronic from glomerulonephritis. Okay. What are some signs and symptoms of glomerulonephritis? Again, a lot of these are so similar, right? So don't overthink it. You guys at least know a couple of the signs and symptoms of glomerulonephritis. Yeah, these are good answers. So, fever and like the strep, like, right, that might be what maybe precedes the glomerulonephritis, that they have an infection, that acute strep infection. And then it has that inflammation. They might have that back pain, the flank pain. They might have some blood in their urine. Somebody, I think, did you copy and paste in the book? This is like word for word. White blood cells, red blood cells, and protein in the urine, right? It all leaks out into the urine. Excuse me. So good job. So again, oliguria. What is oliguria? Yeah. Yeah. Oliguria, less than 400 mils in a day. Not enough. When we talk about urine output, how much should patients, actually, I remember that I asked you a question, so I'm not going to ask you this. Never mind. Going back, signs and symptoms of glomerulonephritis. High blood pressure, right? With that backup, it's going to cause an increased pressure in the rest of your body. You're going to have electrolyte imbalances because the kidneys aren't going to be able to filter out things like they normally would. Because of that fluid backup, you're going to have edema, and then probably pretty well. So diagnostic test, how do they know you have glomerulonephritis? Well, they're going to look here. And we're going to talk about this a little bit more when we have our patients when we do our lab work. One thing I really want to point out though with the BUN and creatinine is those are two kind of the key lab values. We're looking at the kidney itself. BUN is, anybody know what BUN stands for? Yeah, not creatine, blood urea nitrogen. So it's really how our body's filtering out nitrogen. Creatinine is a waste product that our body filters out through the kidneys. So and I think of a video that will show you this in a minute, but our bodies essentially, when we're kind of filtering things out, the kidneys filter out most of the creatinine. That kind of goes away, that's excreted in our urine. The BUN, that can get reabsorbed, depending what our body needs. So sometimes you'll have patients with kidney disease, and the BUN and creatinine will both be high. There's going to be some patients, like with dehydration, if they're very dehydrated, they're not going to be making a lot of urine, right? Because their body's going to be conserving all of that fluid. Now, we don't reabsorb creatinine, so that number is not going to go up, right? They're going to still, even with dehydration, they're going to be excreting that creatinine. But the blood urea nitrogen, because that does get reabsorbed, and that would get reabsorbed like with all the, because they're not, they don't want to like flush out more than they need. Our bodies don't want to flush out more than they need to when they're dehydrated. You might see elevated BUN when our patients are dehydrated. So sometimes you look at patients, you're like, oh my gosh, the BUN is really high. How do I know if this is kidney disease or something else? Well, look at the creatinine. If the BUN is high and the creatinine is high, that says that probably is some kidney disease. If the BUN is pretty high, but the creatinine is still low, that tells me it's probably dehydration that's going on. And we can look at some other lab values that kind of help us see with dehydration. Things like their sodium and stuff like that can kind of give you an idea. Hemoglobin and hematocrit sometimes can. Okay, anyway, that was just a little journey that we took. But now you guys know when you look at BUN and creatinine, it does tell us about kidney function, but it doesn't mean that, it's always indicates, BUN doesn't mean you always have kidney failure. Diagnostic test. we're going to be looking at their urine, right? It might probably going to be dark. It might be foamy. Again, some of those, the liver being affected by this. They're going to be spilling out the white blood cells, red blood cells, proteins, all of that in the urine. Do you guys remember from the video last week what casts are? Yeah, when the white blood cell kind of, they all clump together inside the tube and then they stay clumped together. And then when we pee it out, it still stays in that little form. And it's called a cast. We might do a biopsy, make sure there's not like a stone or something else that's in the kidney causing damage. And then, did I say biopsy? What I meant to say was x-ray. Do an x-ray. If the x-ray shows there is maybe a mass or something going on, they might actually biopsy that, or they might do like a random biopsy to try to confirm that it is glomerulonephritis. So what do? Most cases, unless it's the chronic glomerulonephritis, will resolve themselves within about a week. So we want to do a lot of supportive care. Vital signs, symptom support, right? If they're really edematous, if their feet are really swollen, then we have to take care. Let's get them still drinking a lot of fluid. Let's get them extra protein in their diet because they're excreting out all of this protein. Rest. I said extra protein, that's afterwards. Sorry. You don't want to give them more protein during this acute phase because it's harder on the kidneys. After if it's resolved in about a week, we want to really up their protein intake afterwards because they have probably lost some of their protein in their body. They probably maybe wasted a little bit of their muscle, and we want to give them good nutrition after. Sorry about that. Okay, this is another short video. Actually, this one might be like 10 minutes, so it's a little bit longer, but I think it's a really good one to just show us like the visual of how the kidney works, okay? Lights on okay, or are we gonna fall asleep if I turn the lights off? We're okay either way? Okay, I'm just gonna see, let me know if you can't see it very well.
Acute injury.
Guys? Okay, did anybody watch those videos that I put online over the weekend? Welcome. Let me get out of here. Okay. I like those videos just because I feel like the visual piece of that is helpful. What do you guys think? Was this one kind of helpful putting the visual together as well a bit? Yeah. Okay. If you want, we're going to talk about a little bit about the like we talked this video is about intrarenal injury, which again, like there's those three types it kind of mentions a little bit. What was the pre-renal acute injury? What's that? What causes that? Yeah, the blood, there's not enough blood flow to the kidneys, and so they're getting kind of, in my head, I think of like shriveled up, like they're just not getting the blood flow that they need. They're not really getting shriveled up, but that's causing some failure. The post-renal failure, what causes some of that? Yeah, like a blockage, like we talked about last week. When you start having a stone or prostate or something, you can't excrete that urine. That's when you get that hydrouret or hydronephrosis. And because the kidney is just getting so much pressure, everything's backing up, that causes the damage. A lot of what they're talking about here, that intrarenal failure, that's something that's actually wrong with something inside of the kidney itself. So it's always nice to know when you have somebody, when you look at their labs, you're like, oh, the BUN and creatinine are up. They do have issues. Now we want to look at what caused it, right? Because it doesn't mean that something with their kidney itself is wrong. It might be they were really dehydrated or they had a lot of blood loss. Or maybe they have a blockage that's causing them to have the issues. We always want to make sure we're using that critical thinking and not just saying, oh, they have kidney failure and that just is that, but to know what's causing that to happen. Moving on. I think we're closest to the end. I think at about 9 o'clock we'll take a break. So wherever we're at 9 o'clock, we'll take a break. All right, moving on. So acute kidney injury. The video kind of explained a lot of this. So if I talk a little bit quickly about it, if you have a question, just let me know. Raise your hand, hit the, oh, I don't have the question emoji. Oh, okay. If you're not comfortable raising your hand, kick your neighbor, how do you make that? So azotemia, that's when the waste products kind of accumulate in the body. Acute. Now, something I don't know if it really says here, but it's usually, oh, it does say sudden loss. Haha, it does. So it's usually very sudden onset. So whatever caused it, it's not like you're slowly seeing the lab values creep up and you're slowly seeing all these signs and symptoms. It usually happens pretty quick. You're like, oh, wow, what is going on with this person? They're oliguric, which we talked about. And then we talked about the mechanism of injury, right? It might be that there's not enough perfusion, not enough blood flow. There might have been an injury, maybe a sensitivity to something. And if we can figure out the cause and reverse it, then their kidney can go back to normal and they can have regular function. There's these phases, and somebody mentioned that earlier. There's the initiating phase, right? That means whatever happened, whatever caused the kidney injury. If they're like from a pre-renal, maybe it was got hypovolemic. They got really dehydrated. They didn't have enough blood flow. Their pressure was low. Then they go oliguric, right? And they're not making much urine. Eventually, they'll start getting, their kidney's not working very well. We start maybe perfusing them, getting more fluid in them, trying to get them, back healthy. Hopefully, it'll move to the diuretic phase, where now all the waste products, everything that's backed up is going to be flushing out. And then they go to the recovery phase and back to normal. So if somebody can recover from acute kidney injury, they kind of always go through those phases where you have the cause, the initiating factor, the kidney kind of stops working, then it kind of not over functions, but it's like making up for lost time and then back to normal. They usually, yeah, if they're at home, it's usually something they're like, wow, like this person looks really dehydrated or they're super edematous or something, like what is going on? Like, and when I say sudden, it's not like life-threatening sudden. Especially when we talk about the chronic kidney disease is a very slow onset usually. This one is usually over a few days, something kind of happens. And so, can we stop it? If something's already started to damage that kidney, we might not be able to do something to stop it from happening or that initiating phase. But we might be able to kind of shorten the uric phase, you know, get them a little healthier quicker. Does that kind of answer the question?
Sort of, I mean, sort of like, cause what I'm saying is that for like all your labs, they have to already be kind of.
Right.
You can take the labs and take the culture and saying.
Gotcha. And you're looking at other signs and symptoms too, right? Like if you're in a long-term care facility where somebody doesn't have labs, you know, how much is their urine output that really drop down that less than 400 a day? You know, or they're gonna be able to see there's other things happening with them. And sometimes there's not a lot to see. You're just like, oh, okay, this is happening now. Yeah. I love that we want to try to keep ahead of all of it, but sometimes not as much. Hey, Joosh.
Sorry, but I was coming to talk about having.
Oh, no worries. I don't know. Abby's doing foundations upstairs. I don't know if Abby's teaching today.
She's gonna be here after this class. For that. So we're doing.
It's always nice to see you.
You're matching up.
Very cute. Very cute.
Yeah, you don't have anything to do really with this. I took off the sheet. The files. If you, can I just say something real quick?
Yeah, of course.
You know, for the clinical paperwork that you guys are doing for next week already. I took off one of the forms, so hopefully you guys didn't print everything. Remember the profile form for the concept map patient profile? Yeah, that had pretty much all the same stuff, so I took it off of the list. And I just want to make sure. It just seemed to be, and it was a huge form.
It's huge.
Yeah, so
I think it can be helpful still, like, if we give it as an assignment to like find out.
But I took it off the list of things. Okay.
What are we supposed to be printing?
Oh, and under your clinical, in the module in the paperwork section, there's one file, one little section that says patient care paperwork. You're gonna want that kind of stuff, and you're gonna want to print out like a concept map. To start, if you don't have one already to practice, which you probably do, but it has like your head to toe assessments, your pathophysiology, your drug cards, you know, more blank drug cards, and the lab sheet.
So here's the clinical Canvas course,
Yes.
and here's clinical paperwork.
So the patient care paper, I'm gonna make it a little bit prettier, I think, because
Are these the three you want them, or
the
four?
one that says patient care
Oh,
paperwork
just click on that.
will open up, and I think I might do it different, so it's more visible.
Mhm.
So you could, oh, but I deleted the patient, or the patient care paperwork.
Do you want us to show up to clinicals with all that paperwork?
You will need five. Okay. I mean, should need it.
Yeah.
Probably will. One, two.
So everything except for concept maps profile.
Will it let you open? I might just clean it up and just put them all on there, and then people can just tell me if they want.
Yeah.
Yeah, because that one
So
was.
we'll do that for every week or every day.
Your instructor will tell you. Wait, are you with me? Most of you are.
First.
Yeah. So next week, I'll send you guys a message. Okay. Okay, then I'm gonna clean it up and then I'll give you another question for you. You're going to, yes. So at least,
Your clinical instructor should reach out to you to tell you what they want you to bring. Maybe
so I'll send,
everything that's with the instructors and tell them to tell everybody.
well, cause that's what, I was like, oh, I wanted to try to catch it about Abby, cause I just found out Olga's doing that degree, cause I wanted to know. She was just doing it.
Yeah, Olga and Sky.
So that, because then you guys can. Wanna make sure there's no. All right.
No, not yet.
All
All right, thank you. Okay, I feel like this is a good spot to take a break. Yeah,
So let's take our first 15 and come back at about 10 after. Work for everybody?
okay. And I'm gonna pause the recording so everybody doesn't have to watch this if you're watching the video. Am I sharing? I'm sharing. Well, I hope it's sharing. Looks like it. Okay. So coming back to our acute kidney injury. We already talked a bit about what could cause it, the pre-renal, intrarenal, and post-renal. Again, if you like the video that I showed earlier on the announcements on like Friday, I think I put some videos that are very like central osmosis that talked about pre and post-renal failure. So watch those if you feel like that might help you with the understanding a bit. Nephrotoxins, something that we put into our body that damages the kidneys. When you guys did pharmacology last term, remembering that right, most of you? Okay. When you took pharmacology, you learned that some kidney or some medicines you don't want to give to patients who have kidney failure because they're nephrotoxic. Now, some medicines are just nephrotoxic and we've got to give them to people. We just maybe would give them in smaller doses to people that have some kidney injury or kidney malfunction. So one of the most common nephrotoxins that we give to people is a contrast media, and that's like a dye. So when we talked about our angiograms or we have studies that we inject contrast dye into patients, a lot of times they'll have like a CT scan with contrast. That's really hard on the kidneys. And so they will look at your kidney function. A lot of times your GFR, which are your glomerular, I'm not saying that quite right. So about glomerular, thank you, filtration rate. Sometimes words are hard. And so that's seeing how fast your kidneys can filter things, right? So do you want to have a high or a low GFR? Yeah, we want it to be high. We want the kidneys to be filtering at a pretty high rate. If that number is going low, that means that they're not able to filter and function as well. So if somebody has a low GFR, they might not be a candidate to have contrast dyes. Or sometimes they might say, you know, we really need this study with contrast to see what we need to see. They might give them some IV hydration or do some other things to try to help buffer the kidney. Yeah. I don't think it can be really too high. Could be an indicator of like after acute kidney failure, if you're just like, whew, you're just dumping out a lot, I think it might go up a little bit, but then it should normalize. Some other medications that might be renal toxins or nephrotoxins, aminoglycosides, tobramycin, Renal. Sometimes they're NSAIDs. What's an example of an NSAID? Ibuprofen, like ibuprofen, naproxen, things like that. If somebody has kidney damage, we definitely don't want them to be on that. Sometimes people will overdose on those, sometimes intentionally, sometimes not intentionally, and that can cause damage to the kidneys. And then other times just chemicals in general. You know, like artificial, they might ingest them on purpose or on accident, or they might work in an area that they accidentally are just exposed to it, and that can cause damage to the kidneys. So while while the nurse is caring for a patient, what's the priority to prevent acute kidney injuries? We check the GFR prior to contrast media or nephrotoxin. We read protocols to prevent contrast-induced nephropathy. Hydrate before and after contrast media, or monitor nephrotoxic drugs. Wordy answers. I pulled that right off of F.A. Davis. I want you guys to get used to those tough publisher questions. All right, and yeah, we want to check the GFR and the creatinine before we give somebody some contrast media. All the other things are things we might hydrate before or after, but really our priority action is to make sure that if we have a study for a patient that has contrast dye, we are double checking, right? Just like a doctor might order a medication for a patient, not realizing they have an allergy, they might order a contrast dye study, not realizing or thinking about their kidneys not functioning as well. We are the ones that get to step into that. So prevention, we want to do just like we said, protect them from contrast dye if we need to. We might want to hydrate before. We want to check the peak and trough levels, like if they're getting medications that can be nephrotoxic, we're going to be checking to make sure we're not giving them too much. Their trough level, if you remember from pharmacology, the peak level is when it's at its highest function. The trough level is what you give right before you check the trough. That's the serum amount, like in your bloodstream, of how much that medicine is in your system right before you give another dose. If that trough level should be low, it's kind of high, that means there's too much. You probably need to give them a lower dose because they're retaining too much in their system that could damage kidneys. Therapeutic measures, we want to treat the cause. If the cause was a medication, probably want to stop the medication, right? They might need dialysis or continuous renal replacement therapy. That's something that's kind of similar to dialysis. It's done in intensive care as like a stopgap to try to keep them off of dialysis. Now, dialysis isn't always long-term. Sometimes dialysis, often if they have acute kidney failure, they might need to be on short-term dialysis a few times a week or so, and then oftentimes they can be done with dialysis and let their kidneys recover. Other times, if they have chronic renal failure that develops, then they might need to be on long-term dialysis, and we'll talk about that too. So I'm going to give you guys a scenario, all right? There's an 85-year-old patient who fell at home, and she was unable to get up, and she was admitted to your nursing unit. The patient said that she fell 36 hours ago, and she's been unable to eat or drink. You observe that the patient has voided scant amounts since admission. So when you're planning care for her, what condition do you consider related to the diminished renal output? Do we think that she has renal calculi, hypovolemia, nephrotoxic drugs, or inactivity? I like it when we have some varied answers here. That's nice. Hypovolemia. So this patient fell at home 3 days ago, said she couldn't really eat or drink. So she's probably profoundly dehydrated, right? And we remember learning about that pre-renal injury, where if you just have diminished blood flow, which could happen from dehydration, having poor perfusion, it would be the hypovolemia that caused her issue. The scenario didn't really say anything about nephrotoxic drugs or anything that might make me think renal calculi. So those are the two ones I could kind of easily say, bloop. And then the inactivity, well, if I'm going to say compare inactivity or hypovolemia, to me, the hypovolemia is like kind of more the obvious yes, because all the signs point to that being an issue. All right. So when we talk about urine and our kidneys producing urine, what's the minimum amount of urine we want to see patients produce that would tell us that they have adequate kidney function? There's a number, yeah, it should let you enter a number on here. Does it let you guys?
You just have to slide it over to your number.
Yeah, so the little thing, you should slide it to the number that you think. And this is a pretty standard, no matter where you go. You're gonna be, when you're tracking intake and output, we want to see this being a minimum hourly output for our patients. And you might not be checking it every hour, but what you might do is say, hey, I'm emptying their catheter, I'm emptying whatever they voided. Last time they voided was 4 hours ago. This is how much they have. You divide it out for that time to see kind of an average hourly output. Okay, all right. What everybody put on here? Does it show? Yeah, all right, so 30. 30 is the standard that we want to see at least 30 mils an hour of our patients voiding to show us if they have adequate renal function. If it goes below that, that lets us know that there's something happening, right? It might be from dehydration, right? But that could be that's causing issues to the kidneys. It might be there's an obstruction. It might be something else in the kidney, but that number tells us there's something going on that's not right. Boop, boop, boop. Oh, another one. How fun. This one's a lot shorter, but this one talks about chronic kidney disease. Okay, so chronic kidney disease. Anybody know somebody that has chronic kidney disease and does some form of dialysis? Yeah. Yeah, usually there's a few people that have loved ones and whatnot that have been on dialysis for a while. It's quite a change in the way of life, and it really does affect almost every aspect of that patient's life and how they plan out their day and week and everything. It's the ninth leading cause of death in the US, complications from long-term kidney failure or chronic kidney disease. And so it's something that I think is important for us to realize, that we will be seeing a lot of patients that have chronic kidney disease. Now, when we talked about acute kidney injury before, a lot of times that's reversible, right? Or most of the times that's reversible. It can develop into chronic kidney disease, but chronic kidney disease, once you actually enter into that stage where like it is damaged enough, we can't go back. It's not like we can fix it with anything. We just have to treat it, essentially treat it as heart treatment. We talked about a lot of the different ways in the cause. It all starts out as something damaging, and then just keeps progressing until eventually there's too much damage for the kidney to be able to recover from. That's why it's a gradual thing. Usually it happens over time. A large portion of the nephrons are damaged. I forgot to look up. Anybody remember how many nephrons? What's that? We have about 1 million nephrons. Yeah, each kidney. It's amazing. I don't remember the number that has to be like damaged for eventually you to enter into like where they can't recover. But it's a really high number that you can have of that 1 million, a fraction of them still working. And your GFR and your creatinine and BUN all still look normal. Like your kidneys are incredibly resilient and keep functioning even. That's like if like you have a big company, a warehouse that works, and all of a sudden over time, less and less people, you have 1 million people that work there, and you have less and less and less and less and less and less, but they're still pumping out the same amount of whatever they're making each day. Yeah.
So when they talk about like the stages,
Mm-hmm.
is like a patient was talking about that she was stage 4, and
Mhm.
they came in and said she was stage 5.
Yeah.
She was like, how does that go so quick, from stage 4 to stage 5? Is it by the nephrons dying?
Somewhat.
Or-
Yeah. Yeah. That's part of it as well. And a lot of times we don't even know, because with kidney disease, you're still functioning well. If you look at people, you look at their labs, they're still functioning normally, even though maybe only half the nephrons are working. And so by the time we have symptoms, there's been a great deal of damage that's happened already. It's crazy. Look at, there's numbers right on here. So renal insufficiency, when we start seeing some of the symptoms, they've already lost 75% of the nephrons. And then when we get to that end stage, they've lost 90% of the nephrons. Isn't that crazy? Like we first kind of see this insufficiency when 75% of the nephrons have stopped working. That's just crazy to me that our bodies can function not too bad with 25% of them. So we're going to see, like it talked about, that uremia, where we have a lot of that urea in the blood. And chronic kidney disease, I just want to make sure we know, it affects all of the organs in the body, right? Because it filters all of our toxins, waste products, extra fluid. And when that gets backed up in our system, that affects all of our other organs in our body. So signs and symptoms, typically what we see with somebody when they have chronic kidney disease is that fluid accumulation. So they get really edematous. They tend to get short of breath. How does that fit into the fluid accumulation? Yeah. Do you guys remember back from anatomy and physiology and maybe from foundations, how the flow of blood through the heart, right? If you have too much volume overall, that blood flow is going to get backed up into the lungs, right? So you have edema even in your lungs all the way through your system. You can have these electrolyte imbalances. Your elevated potassium is probably going to be the most critical one that you'll see with these patients. Most of the time, when you look at your patients with chronic kidney disease, you're going to want to know what their creatinine is, and then you're going to want to look to see what their potassium is. Because what's one of the main problems we see with patients who have potassium imbalances? Yeah, cardiac arrhythmias. So these patients, we're not able to get rid of that extra potassium. You see them with like a potassium of 7 or like just, it's crazy. And so we're like, oh, let's get you into some dialysis. Let's figure out how to get that potassium level down because that's kind of dangerous. They do have acid base imbalances. You know, if you go back to MedSurg1 and we talked about, you know, the different metabolic imbalances that you can have. Kidney disease, that drives a lot of it. And then anemia. What's that hormone that our kidneys produce? Erythropoietin. Yeah, that stimulates the bone marrow to make red blood cells. And when the kidneys are damaged, that hormone doesn't get produced. Do you guys know there's a medicine that we give patients with renal disease? I can't remember the name. It sounds kind of like erythropoietin. It's called E something. I don't remember. But anyway, essentially, it's just an artificial hormone that we give patients with kidney disease to help stimulate their blood flow, their bone marrow to make red blood cells. So just knowing that, that's another thing. If you have a patient, when you go to clinicals and you're like, oh, they have chronic kidney disease, you're gonna look at their labs. Also, what's their red blood cell count? What's their H&H, right? Because they're probably gonna be fairly anemic. And that's just even if they get medications to help that. So here, I don't love this picture, but it kind of does a good job of showing all the systems that are affected by the by kidney failure. So your neurological system, you get just general fatigue. A lot of times these patients are depressed. They can get headaches. Because of these electrolyte imbalances, seizure and coma. Respiratory, we talked about getting short of breath. The renal system, right? Well, clearly they're going to have anemia and probably not producing much urine. They can get a lot of what's called pruritus, itching. Those waste products, your body is just trying to get rid of them. And so sometimes they can excrete some of that through the skin, like the uremic frost. That's pretty extreme. I think I've seen that maybe once early on with somebody who was end-stage renal failure, hadn't had dialysis for quite some time. And so that urea started to kind of, their body's just trying to excrete it through their skin. But they do get very itchy and dry. They can get a little bit yellowish skin. They're prone to fractures because their body has difficulty with calcium regulation. And so it's pulling calcium from their bones. A lot of times these patients, we give them calcium supplements to try to offset that. Gastrointestinal system, they have a lot of like slowed down of their GI tract. Again, that extra fluid pressure on there, it causes difficulty with getting everything through. They have high blood pressure, heart failure, arrhythmias, and it doesn't say it on here, but they're always cold. You ever take care of chronic renal failure patients? They always want a warm blanket. They're just always cold. I don't know if that's the anemia or if it's just byproduct of if they're on hemodialysis, their blood's getting taken out and filtered and it's warmed, but I don't know if that just does something to them where they feel cold all the time. All right, so therapeutic interventions, we really want them to have a high calorie diet, but we want to try to restrict the protein again, because it's harder for the kidneys to digest. Now, if they're on dialysis, we let them have more protein because the dialysis itself, that's going to be able to filter out some of the protein. We try to have low sodium, low potassium, low phosphorus, because they're not going to be able to excrete those like they normally would. We're going to give them some vitamins and supplements because they're just not going to be probably eating as well as they should. And a lot of times we have them on a fluid restriction. You guys ever had a patient on a fluid restriction? What's like a typical fluid restriction number we might see? Yeah, 2,000, 1,500, 1,200. I've seen down to like 1,000 or 500 with extreme cases. And so that means like if you're on a 1,500 fluid restriction, that's the whole day. That's 24 hours. I used to work night shift and I used to get so irritated with day shift because I'd get a report and they'd be like, okay, they're in a 2,000 milliliter fluid restriction. I'm like, okay, how much have they had? They're like, oh, 2,000. I'm like, great. Now I'm going to have a really unhappy patient all night because I can't give them anything. How am I going to give them their pills? I mean, you still have to give them their pills. You're going to go over your fluid restriction, right? Because they still need their medication. You know, you're probably gonna throw some ice chips at them because they're gonna feel so thirsty, that kind of screws you over. So if you have some kind of fluid restriction, try to think about it's a 24-hour thing and be nice to the people on shifts that you're not working, right? Because they're gonna get thirsty overnight or need medicine or want something. Okay, that was just a little soapbox. Let's get back. So what kind of medications are we gonna have them on? Hey, we're gonna talk about that in our medication activity, but it's gonna be a lot of like treating and trying to do what the kidney normally does. So diuretics, right? Get rid of the fluid, lower your blood pressure, phosphate binders, right? Trying to get rid of some of that phosphate so it's not increasing the system. We're gonna give them vitamin D and calcium as well. A little side note, why do we always give vitamin D with calcium? Right, it absorbs. We can give people calcium till the cows come home, but if they don't have any vitamin D, they're not gonna absorb it. So we always wanna make sure it has vitamin D. When you look at milk in the store, right, usually it says like vitamin D milk, or it says something in there because milk is a good source of calcium. And if we just put the vitamin D in there, we know people are gonna be able to absorb it. Let me go back really quick. Potassium reducers as needed. So we know these patients with chronic kidney disease, their potassium levels are going to go up. And so these are some ways to get it to go down. So calcium gluconate, that can help shift the balance of intracellular and and blood levels of potassium. We also, if we give insulin and glucose IV at the same time, so in your IV, we give them IV insulin. At the same time, we give them IV glucose. That actually shifts the potassium in the cells as well. And you guys won't be doing that. That's going to be an RN or somebody with a higher degree than that giving that. It's kind of a critical medication, right? IV insulin is pretty tricky. We might do Kayexalate. Anybody seen a patient with Kayexalate before? That is given orally. And what it does is in the GI tract, it pulls potassium into the stool. So if we think about anything that we're pulling something into the stool, what's going to be a result of that? They're going to have diarrhea. They're going to be pooping a lot and it's not fun, but they do the Kayexalate so that they can pull that potassium down. And then Petroximer, I don't think as usual. So therapeutic interventions. We're going to have them on dialysis if they meet criteria. If they hit their fluid overload is too extreme, if their potassium is high, they start having neurological signs like the ataxia. It's like this bird, like kind of this flapping hand thing. If somebody gets too high with that urea, they start having those symptoms. So check your patients when you go to clinical. If somebody is on dialysis and they're going to go later that day, do an assessment, see what you can find out. That was interesting. All right, so let's do a quick activity. You have a patient who came to the unit with renal disease, kidney disease, and we're just going to say that's chronic kidney disease. Their calcium level is 9.5, potassium is 7, magnesium is 2.0, and BUN is 18. What do we do? Try to reduce the potassium. So in a clinical setting, you guys are going to be the nurse. As a nurse, what does the nurse do? Inform the provider. Always a good one. I was talking to our full-time cohort yesterday. I'm going to have them in clinical next week. And that we were talking about, like, it's a definite shift of being like, this is what we would do, but also like if we are the nurse, right? We're not a nursing assistant anymore, or we're not just talking about it's like, oh no, I am the nurse. What do I do? And yeah, inform the provider is probably the best thing, right? Because a potassium of 7.0, that's pretty high. They're very much at risk of starting to have cardiac arrhythmias. So hemodialysis. Now, once they start on hemodialysis, you don't stop. You have to continue that the rest of your life. It's where they say artificial kidney, but it's essentially a big machine that works like the kidney does to remove the extra waste, the toxins. There's a couple of ways you can do. You have to have a vascular access, right? Because it filters the blood. You can have a temporary vascular access, and that's where maybe somebody, and I would say dialysis is permanent if they're chronic kidney disease, right? if they are acute kidney injury and they have to be on dialysis short term until they enter that recovery phase, then they can stop it. So I'm talking just about somebody with chronic. So a temporary venous access, usually that would be an internal jugular IV, or sometimes they'll do like a tunneled subclavian. Do we have one for baby consumption anymore? Maybe that one upstairs. I don't know where he went to. Anyway, but you can have short-term dialysis access. Usually those are just for a week, sometimes a couple weeks if it's a tunnel line. Typically, if they're gonna be on dialysis long term, they're gonna have a permanent access. And that's where you have AV or arterial venous fistula or a vascular access graft. A fistula, or excuse me, the fistula, I believe, is where they take your own blood vessels and tie them together. Do I have a picture after this? Here we go. So the fistula, and that's where they kind of tie the artery and vein together so that the blood flow is kind of mixed, right? And then when they go and have dialysis, they do two different access points. Bloop, bloop, and one pulls the blood, sends it through the machine to filter out. The other one returns it back in. With the graft, it's an artificial tube, essentially, and that's what the blood flows through, and that's what the dialysis staff would access when they're doing dialysis. Now, this kind of shows this patient how there's one line coming in, one line going out. We all know that blood is not blue and red, right? Like, I still fight with my family over this. They're like, Mom, you know blood. And I'm like, oh, please don't tell anybody your mom's a nurse. I'd be so embarrassed if you told them that. Anyway, but that's the colors to show you how the blood goes out through here, goes back in. To do this, they have dialysis techs. But typically, it's RNs who do dialysis itself. So if you go on to school, you could be able to do this. It's very complex. You work with the provider very closely. You measure as you're going how much fluid is coming off. You measure their labs. Sometimes, because these patients are oftentimes anemic, you'll be giving them blood during this as well. It's pretty complex. And let's see. This is a gal who's probably in an outpatient setting. See how there's like a chair here. See the blanket? She's cold. Telling you, all dialysis patients are cold all the time. And usually, if you're on a scheduled hemodialysis, we say hemodialysis because that's blood dialysis. You do that 3 times a week is typical to maintain normal function in your body. People will have schedules like that. Anybody know what the usual schedules for dialysis are? It's days of the week. So usually you're on a Monday, Wednesday, Friday schedule, or you're on a Tuesday, Thursday, Saturday schedule. So these patients, we see why it's so important that if they lose access to their ride, or if not patients who drive themselves, people talk about having profound exhaustion after dialysis sessions. So I can't imagine driving yourself home afterwards. But if something happens, they just get sick and they can't make it to dialysis, and if they're a Monday, Wednesday, Friday person and they get sick on Friday morning, they miss dialysis, then they go through all weekend, they miss Monday. These patients get sick pretty fast. A lot of times they have to come into the hospital, have dialysis, fix whatever is going on with them, and then get them back home. So we really want to do a lot of work with looking at socially, emotionally, all these things to keep them on track, because if they miss dialysis, they're going to get sick pretty quick. Let me go back. So if you have a fistula or a graft, we want to make sure we're checking it. So some of the things we check, because they're mixing the blood flow. Now I point here, this is usually where they start with. Patients who have been on dialysis for a long time will usually have a graft that starts to malfunction, or a fistula that starts to malfunction. Just like when you guys are going to learn about IVs, you haven't done IVs yet, right? You kind of did some labs. Usually, I don't know if you guys talk about, like, you start low and then you work up. That's the same for dialysis as well, like dialysis grafts. They're gonna start here. After a while, it's probably gonna malfunction, not gonna work after a couple years or so. Then they're gonna move maybe up here or up here, and then they might move to the other arm, right? They're gonna use whatever sites. If somebody's had a well-established fistula, they work on growing them, they have to mature them. It's done in surgery, how they put them together. And they like do little squeeze balls and they like work on getting more blood flow. Those blood vessels, they get like big and they're like ropey on their arms. So some things we want to do is make sure that it's not taking the blood flow away from the rest of the arm, right? Because we don't want to like all of a sudden all the blood flow from the artery that's going to perfuse our hand to get snatched away and flow back to the rest of the body. So we're gonna do neurovascular checks on that arm, make sure that they have good sensation, have refill. We also are gonna do, just check their pulses in general, is there still blood going through? Then when we look at the fistula or graft itself, we look at thrill and bruit. So the thrill is what you feel. I feel a thrill. You feel it, and you're gonna feel it's like turbulent blood flow. The bruit is what you hear. Just like when we talk about head to toe assessments, you might listen for a bruit, like in the carotid arteries. It tells you there's turbulent blood flow. We want to hear a bruit in these fistulas because that tells us there's turbulent blood flow. We want that. We want there to be a lot of blood flow through there. We also want to protect the access. You have somebody that has a fistula or a graft, we're going to put signs and maybe a bracelet, something that says, hey, don't you dare do a blood pressure on this arm, right? Don't poke this for a blood draw. We are protecting this because this is their lifeline to have dialysis. And we want to educate the patient about it too. I've had patients who like come in and I'm like, oh, hey, they said you need an IV, and they're like, yep, but don't do this arm, right? Because they know this arm is off limits if they have an access there. We looked at that. Okay, let's check. Were you listening? Which do we feel for? Do we feel for the bruit or for the thrill? Oh, you guys listened pretty good. Yep, the bruits are what we hear. The thrills are what we feel. I think about that older song from Sia, like She Loves Cheap Thrills. You know, you feel a thrill. Thrilling. Okay, so there's another option for dialysis. Not everybody is a candidate for this, but some people are. It's called peritoneal dialysis. So in our abdomen, we have a potential space that is our abdominal wall separated, and if it could be separated from our intestines. So it's a potential space, right? We're not all walking around with this big, we don't have a peritoneal cavity, but it's not open, right? With all of us right here, it's kind of sitting. You're unique. Right? But if we have something that's in there, that might move that space a little bit. So this is the type of continuous dialysis. This can happen a couple, well, we'll get into it. But basically, the peritoneal membrane is pretty porous and it's kind of what we call semi-permeable, that some things will be able to flow back and forth throughout. What we found are the things that will flow maybe back in and out, it kind of mimics a little bit with our kidneys being able to excrete and protect, keep some things. So with this, let me see if I have a picture. All right, so I don't think this picture do it great justice. But essentially here, you can see there's a catheter that's placed in surgery and it comes in and this blue is supposed to indicate the fluid. That's that potential space. If the belly was empty, they didn't have any fluid in there, then this abdomen would be, right? Here's the intestines, here's the abdominal wall. So if you have this catheter, what it does is it's called, there is a line. It's all done kind of continuously. You would you have a bag of fluid, and it's called dialysate, and there's a certain percentage based on the doctor's orders. If somebody needs a lot pulled off, that dialysate is going to be a higher concentration, so it can pull more things off of it. So that most of these patients, they're walking around, they already have some in their belly right then. So we have to empty it out. We belly drain it. A lot of these things have like a three-way system. So you hook them up, you drain it out. Usually only takes like a half hour or so. Sometimes when I did it, I would have patients say, hey, we really have to go with it. So we can get it all out. And then after it was done draining, clamp it off and then you open the flow. Fill it. And then once it's filled, it's in their belly. Unhook it. And then they go about their day. Now that's if they do it throughout the day. Sometimes people will do, they go all day without. And then at night, they have one that kind of continually, it has like a timer and it cycles them through. They can do that at home. But you can see how to be able to manage this catheter, manage hooking yourself up, draining it out, evaluating it, that would take a lot of some critical thinking, some skills, some socioeconomic factors, like you need a home to do that in usually. You need to have good access to healthcare. Not everybody is a great candidate for a peritoneal dialysis. Let's go back. We didn't talk about this. So with the peritoneal dialysis, just a couple things. You want to make sure, like, what are some complications we might see with them? Yeah, infection's a big one, right? We're introducing things every day into that cavity. So what might be some signs of infection that we see? Yeah, fever, the drainage might be cloudy. Belly pain is one of the biggest signs, that kind of inflammation. Yeah. When I was doing this, and this was 20 years ago, as a baby nurse, what did I know? I didn't know nothing. I can't believe they trusted me to do these things. And if somebody started to have peritonitis, the doctors would order antibiotics. And we would get the antibiotics from pharmacy and we would put them in with through that peritoneal cavity. And we would do that for the, ordered length of time, and that would help resolve the peritonitis. So interesting. Okay, so another option patients might have is they might be a candidate for a kidney transplant. Now, because our kidneys are amazing and we're gifted with 2 of them, you could actually donate a kidney. So sometimes people, polycystic kidney disease or other issues, they might want to get a kidney transplant. And so sometimes, especially if you're a family member, you might be a closer match, might be able to donate. You can also have a cadaver donor, which that just means if somebody passes away and they want to donate their organs. Now with like with organ transplantation, typically it has to be somebody who they talk about like brain death and they donate the heart and lungs. Kidneys are another one of those large organs that it's more difficult to get. So that's why it's kind of, I don't say nice for kidneys, but that, a lot of times people can donate a kidney to someone else. Now, because somebody has a new kidney from a transplant, that doesn't mean that now they don't have to take care of them anymore. They might not have to do dialysis, but they do have to take anti-rejection medication for the rest of their life. They have to have follow-ups and labs for the rest of their life as well, just to make sure everything is going well. This is kind of fun. Some people don't realize when you have a diseased kidney, I like how it kind of shows them shriveled up. They look like raisins. They don't actually take your diseased kidney out. They just put the new kidney in. So sometimes I take care of people who have 4 kidneys inside of them because they've had a transplanted kidney and then that one failed. And so they got another transplanted kidney. And so they have 4 kidneys inside of them. Only one of them was working because it was the new transplant. But they like this here, they just tie that new kidney, usually a little bit lower into the pelvis. So anyway, our bodies are crazy, aren't they? No reason to. They're not doing, the old kidneys aren't doing harm. They're not doing anything bad necessarily. And so it's rather than causing potential trauma or causing a potential issue by taking it out, they just put the new ones in. Yeah, we got a lot of potential space in our belly, right? Yeah, you're a walking proof. Here's some nursing diagnoses, nursing care. We talked about all this already. Chronic kidney disease. We talked about this. Okay. I don't want to do this right now. I want to move to concept maps. Oh gosh, I think we're time for another break. Let's take a break. When we get back, don't sit where you are. Or if you do, sit with your group, okay? So when you take a break, let's do 15 minutes, so 10:15. When we come back, we're gonna start some group work.
Making a calendar. I'm busy in my. She's like, oh, I'm gonna